Hello and welcome to the next in our series of interviews for the Midlands Science Festival. The Midlands Science Festival is hosted by Midlands Science, who are based in Tullamore, County Offaly, and is supported by Science Foundation Ireland as part of the National Science Week programme. I'm Craig Slattery, an Assistant Professor in the School of Biomolecular and Biomedical Science in University College Dublin, and this morning I'm delighted to be speaking with Dr. Kate Gajewska from Daibetes Ireland, who is going to talk to us about diabetes care and management in Ireland. Kate, it's wonderful to have you with us and looking forward to hearing all about diabetes care in Ireland.
Hello everybody, hello Craig. Thank you for this opportunity to let us talk about diabetes today. Thank you.
So Kate, maybe to start, you could tell us a little bit about Daibetes Ireland and what it is you do day to day.
So Daibetes Ireland is a national charity, the only one national charity focusing on diabetes and on people living with diabetes in Ireland. We provide diabetes education, we provide awareness sessions, we provide healthcare, health promotion, we have a helpline for people with diabetes. We also are very strong when it comes to advocacy, so talking to politicians, decision makers, highlighting the issues. We have our Daibetes Ireland advocacy group. We also have Daibetes Ireland Research Alliance because we always support research and Irish researchers. We also conduct our own research within Daibetes Ireland and within the community. So we are all about diabetes. We organize events, we organize picnics, camps for people with diabetes, health and awareness sessions, mental health workshops, webinars. We do a lot, but we are a very small team. I just would like to highlight it. And we work a lot for all people with diabetes to have better quality of care and better lives with diabetes.
You've listed an awful lot of activities, and as you say, it's a small enough team, so that's really impressive in itself. But it's fair to say that the people who have diabetes and how they manage their care, that's really at the centre of what you do.
Absolutely, people are at the centre. We always try to help and support them within our helpline. People can always call and ask questions. We can always advise where to go to get appropriate, for example, treatment. We also try to intervene if there are any issues. We talk to politicians. We talk to the Minister of Health as well. We launched our pre-budget submission this year. It's our second pre-budget submission. We highlight what the issues are in diabetes community and what we would like to see improves in diabetes care in Ireland. We also support healthcare professionals. We organize conferences for them. We let them train and learn with us as well. So yes, we are all about people living with diabetes and people who work in the area as well.
It's a very interesting job personally for you, and I'm wondering how you came to work in Daibetes Ireland. Could you tell us a little bit about your own background and your own education?
Yes, absolutely. So I'm a psychologist by background. I trained in Poland, but while I was finishing my studies, I had to conduct a master degree, and I wanted to do it in the area of exercise psychology. And then I thought, okay, I have a background in diabetes because I'm also a person living with diabetes. And I thought, okay, I can combine this too. So I started to work in the area of diabetes and health psychology and sports psychology, conducted my master's. And in the meantime, I started to run a little project focusing on education for people with diabetes, with mainly type 1 diabetes. I organized many workshops, many webinars. I launched my own YouTube channel, and I was educating people about diabetes. And then I started to work as a diabetes educator and psychologist in pediatric outpatient diabetes clinic in Warsaw. And then I moved to Ireland, where I worked in one of the pediatric hospitals as a research data manager. I then conducted a PhD on accessing diabetes technology in RCSI, Royal College of Surgeons, in Dublin. Then I started to work as a lecturer, and my all experiences brought me to Daibetes Ireland to work as a research and advocacy manager, because diabetes is what I'm the most interested in. That's my career choice, and that's somehow my life choice that I didn't choose. But yeah, I can talk about diabetes for ages, so you always have to stop me.
So this is the Midlands Science Festival, so we do need a little bit of science in the mix. So maybe you could tell us a little bit about the science behind diabetes and how it develops, what happens in the body, and maybe some of the symptoms that people should watch out for.
Yes, so diabetes is a condition characterized by chronic hyperglycemia. So hyperglycemia is an issue. It means that our blood glucose levels are elevated because of many different reasons. There are different types of diabetes, so that's why I would like to explain it a bit more, because type 1 diabetes, so the type that I have personally, is an autoimmune condition. So my body does not produce insulin, very, very important hormone that is responsible for the regulation of glucose and getting energy from glucose. So I don't have it, and that's why I have to treat diabetes, because without this hormone, I can't live. The other type of diabetes is type 2 diabetes. People with type 2 diabetes do have their own insulin. Sometimes they have a lot more than they should, but what their problem is insulin resistance. So their body is resistant to the way how insulin works. So that's why they have to treat diabetes to reduce this resistance and do their job, lifestyle intervention mainly, as well as different tablets and treatments to try to their body work better with insulin that it produces. And then there is also a third type of diabetes. It's a gestational diabetes. Gestational diabetes happens only to women who are pregnant. Because there are just so many hormones, these are causing hyperglycemia, and this is why women who are pregnant have to treat diabetes until the baby is born. So there are three main types. There are also a lot more. There are different types of genetic types of diabetes, MODY, LADA, LADA. There are many of them, but the issue is one, hyperglycemia, that has to be tackled.
Okay, and so you mentioned the different types in there, and I suppose there's always the issue that we get with media, and sometimes there can be a bit of confusion from that. So I know that type 1 diabetes for a long time was regarded as juvenile diabetes, or that only children could get it, or if it was diagnosed early in life, it had to be type 1. But that's not necessarily the case anymore.
No, not at all. And we know that thanks to research and thanks to epidemiology that is growing, and we have a lot more data, we have a lot more diabetes registers in other countries, unfortunately not in Ireland. But what is happening and what we do see is that these patterns and characteristics of different types of diabetes, we usually think, as you mentioned, that type 1 diabetes is only in children, because this is one of the most prevalent chronic conditions in childhood. But any person can get diagnosed with type 1 diabetes. You can be at any age, you can be over 50, you can be over 60, and according to Biobank study from the UK, more than half of newly diagnosed cases of diabetes were diagnosed in people over 30. So it's not that it's only pediatric issue, absolutely not. And then on the other hand, we have type 2 diabetes, which is all usually assessed with the age. So the older you are, the risk is higher to develop type 2 diabetes. However, we see that the patterns are changing back again. We see that younger people are getting diagnosed with type 2 diabetes, 30-year-olds, 40-year-olds. It's the most prevalent chronic condition for people over 45 in Ireland. And we also see, fortunately not too often in Ireland, that kids and adolescents can also be diagnosed with type 2 diabetes. It is not the big case now in Ireland, but the risk is always there, because it all comes back to nutrition and how do we really live, because it's a lifestyle condition.
Yeah, and so we are always hearing about associations, particularly with type 2 diabetes and obesity and having a healthy BMI. And is that one of the main, you mentioned the increase in the prevalence and increase in the incidence of diabetes. Is that one of the main things that's driving that?
Yes, absolutely. Like obesity and overweight is a big risk factor. Also the genetic background, the genetic load is a big risk factor. Gender is a risk factor as well. Social deprivation is a risk factor. So what do we eat and how do we eat, and how much money do we spend for food? Like eating healthy is not the cheapest option. So that's why, for example, prevalence of diabetes might be higher in low socioeconomic backgrounds. Type 2 diabetes definitely is associated with weight, and it also happens that if you're diagnosed with type 2 diabetes, the first intervention is to try to lose weight, and then you can limit your risk, you can decrease the risk, or you can even get rid of diabetes and have remission. It happens. But it's not always the case. In some cases, you have very strong genetic load and you can be fit and healthy and you still might develop some type of type 2 diabetes. So I wouldn't like to only associate type 2 diabetes with weight, because we also know that there's so many people with obesity who don't have diabetes. So it's a combination of different factors, genetic factors, risk factors from even our socioeconomic backgrounds that may increase it.
So you mentioned insulin. And one of the reasons that we're having this chat is because this year we're celebrating 101 years since the discovery of insulin. Insulin is, of course, a medicine, and it's a really important part of managing diabetes, but it is about managing diabetes, and maybe you could explain a little bit more about the whole process.
Yes, so insulin is a hormone that works to reduce the hyperglycemia. So all people with diabetes who are using insulin are also at risk of having hypoglycemia, so the opposite thing. So if you overdose the insulin, you might get your sugar levels too low. And this is the reason why diabetes management is not easy. It's not that we only take one tablet a day when we use insulin. It's delivering insulin for each food that we eat. It's delivering insulin for the whole body needs, for the whole 24 hours a day, 24/7. It's a demanding condition when you have to use insulin, because you have to also control your blood glucose levels. So you have to know what dose to deliver. You have to know what do you eat, because based on the carb content, the amount of carbohydrates in your food, this is how you calculate the dose for your meal. People with type 1 diabetes who have to deal with delivering insulin to each meal, there was estimates that somebody has estimated that more than 30, 40, 50 decisions a day, 50 medical decisions a day have to be done each day by a person living with this condition. But when we talk about type 2 diabetes, some people also have to deliver insulin, so they're at the same risks. They have to do the same, they have to calculate their doses. They also have to monitor their blood glucose levels. But what is also important, people with type 2 diabetes have a lot more lifestyle changes to make. So they usually need to implement more exercise, they need to lose weight, that's the usual recommendation. They also need to reevaluate their nutrition and diet and eat more healthily. So anyways, whatever type of diabetes you're diagnosed with, it requires huge changes in your life and huge amount of time that you have to spend on learning how to live with diabetes.
So what you described there, it's highly individualized. So on a day-to-day basis, a person living with diabetes, as you say, they have to make up to 50 individual medical decisions for themselves. So it seems like having data is a really important part of that. And obviously nowadays with smartphones and smart devices, there are probably very good ways of getting that information.
Yes, absolutely. There is a huge change in diabetes care in the last decade, I'd say. We are moving towards technology use. So technology has improved dramatically in the last 10 years, and now people with diabetes, those who are using insulin mainly, can avail of continuous glucose monitoring systems, flash glucose monitoring systems. They don't have to finger prick, they don't have to check their blood glucose levels just by getting their blood drop and then see what's the result. They can have everything on their graphs, they can see what is happening, whether their glucose levels are rising, falling. They can make a lot better decisions when it comes to their insulin therapy and even diet, because people with type 2 diabetes are using technology too, even if they're not using insulin, because it shows you what happens in your body. And funny enough, continuous glucose monitoring systems as well as flash glucose monitoring systems are used by people who don't live with diabetes, but they want to, for example, improve their outcomes, their sport outcomes. Some sportsmen are using it. Technology changes lives dramatically. Another technological change is an insulin pump. Insulin pump is a small device that keeps the insulin, and if someone wants to deliver insulin, then this person has to just click a few buttons. So it's a lot more tailored type of therapy. You can tailor all your insulin needs instead of injecting every couple of hours. So it makes a huge difference. But now the most emerging type of technology is automated insulin delivery system that combines both aspects. So one is an insulin pump, the other one is continuous glucose monitoring, and there is a special algorithm that calculates the insulin dose from glucose values and then informs the insulin delivery, and insulin delivery is conducted automatically. It's a great help. It's an absolutely fantastic device for any person who has to significantly make all of those decisions a day. It's a huge help, but we still have to provide information about what do we eat, whether we exercise or not, etc. So this all data are there. It's much easier to analyze this data if we have them within those systems. And yeah, technology is definitely a way to go, and that's what the majority of diabetes community is saying, both for type 1 diabetes and type 2 diabetes.
You mentioned that type 2 is insulin resistance. So I'm just wondering, is there a difference then, or are there additional medications that are needed with insulin?
Yes, absolutely. It's worth to mention that among people with type 2 diabetes, approximately 10 to 20% would be using insulin. So the rest, the 80%, uses different types of medications, or they are not using any type of medication at all, but they have this kind of lifestyle intervention back again. So better nutrition and more exercise, aiming to lose weight. Usually, when it comes to medication, oral hypoglycemic agents are very popular. Their aim is to make body reacting better for insulin resistance. So they aim is to reduce the insulin resistance. There are so many different types of other treatments. So there are not only tablets. You have, for example, 1 weekly injections. You have 2 daily injections. Some people would be using insulin, for example, only long-acting insulin, not fast-acting for food. So there are many different treatments. That's why it is necessary for any person diagnosed with diabetes to be seen by well-trained healthcare professional team, because they are the ones who may offer you the best treatment option and option that is suitable for your personal needs.
And it's probably worth mentioning as well that this is not static. There are new therapies becoming available, new approaches to managing diabetes all of the time. So patients and people who are living with diabetes really need to pursue that and push their healthcare providers to give them the most up-to-date treatments.
Absolutely, this is very important. The technology, the new treatments, new products are emerging continuously. The best arena for all healthcare professionals is to attend international conferences, to see the outcomes, observe, of course, read the articles, medical articles in peer-reviewed journals about the effectiveness of different treatments. This is all very important. From my example, my personal example, so I was diagnosed in 1987 when the treatment was very different to what we have now. So I had to have very, very strict diet. I had to eat 6 meals a day. I had to take 2 injections a day, and I didn't have blood glucose meter because there was no option like this to check your blood glucose meter. So for my parents, because I was a very little child, for my parents it was a huge challenge, and it happened to me that some severe complications happened. I had severe hypoglycemia 3 times when I was a child. I lost consciousness, so it was very scary, very risky. But since we have blood glucose meters, and I got one when I was 4, since we have better insulins, so laboratory produced analog insulins that are a lot more effective, then we got an insulin pump that changed the way how I deal with diabetes. Then I start to carb count. Then I got my first continuous glucose monitoring. Then I got my automated insulin delivery system. Even my life shows how much it can improve when it comes to diabetes treatment, and that's why it is so important for any healthcare professional working in the area to be up to date with what's good, because my life now and my life 20 years ago is a very, very big difference between those.
So you mentioned hyperglycemia, and so having too much glucose in the system, in the bloodstream, and hypoglycemia, and how important insulin is then in keeping things in the Goldilocks zone, in that right range. I'm wondering what happens when you're outside that range in the body. What sort of complications can you get?
Yeah, so there are different types of complications. We are talking about severe complications and about long-term complications. So for example, in type 1 diabetes, the biggest issue is associated with the risk of severe complications, because if we overdose insulin significantly and if we have no glycogen, and it's a very, very unlucky situation anyways, we might lose consciousness when we have very, very low sugar. So that's why early recognition of symptoms of hypoglycemia and early reaction. So just to eat a few glucose tablets or just to drink something sweet may bring me back to my normal values, so the values that healthy people have. On the other hand, we are at constant risk of hyperglycemia, and it happens quite often that I have both hypos and hyperglycemias, but I try to catch them early, and this is why I have this technology that informs me what is happening, whether my blood glucose levels are rising or falling. Hyperglycemia is not very nice feeling. You might be a bit irritated, you are easily getting angry, but that's one thing. The other things are very typical symptoms of diabetes that is not yet recognized. And if it's recognized, these are the typical symptoms. So you go to the toilet very frequently, you want to drink a lot, you're super thirsty, you're exhausted. And if diabetes is not yet diagnosed and it's not treated, one of the symptoms is also losing weight. But this is about the symptoms, and we were supposed to talk about complications. So why do we treat diabetes, and why do we invest in that, and why do we make so much effort? Because we would like to avoid the risky effects of chronic hyperglycemia. And the risky effects of chronic hyperglycemia, it does affect our body significantly. So we have a few complications that are very typical, and they are diabetes related. One is retinopathy, which means that eyes are affected. We have nephropathy, which means that kidneys are affected because of the hyperglycemia, so the amount of sugar that is in our kidneys, and it just doesn't go through, and then the kidneys are failing. And the other one is neuropathy. So it's a complication of our nerves, and neuropathy can lead to diabetic foot. Diabetic foot is a very, very dangerous condition, because if we have diabetic foot, we don't feel what is happening, and this is how we can easily get an infection. And if we get an infection and it's not treated, we might even end up with the amputation of our limbs. So these are the most scary complications. We have also macrovascular complications, meaning that our heart can be affected, so cardiological issues. So that's the case. Hyperglycemia is not healthy for our body, and that's why we have to catch it early, intervene early, treat it early, and then our risk is much lower. So yeah, we all would like to see less complications, and this is why we advocate and fight for access for best treatments for people and better healthcare.
Early recognition and early diagnosis is really important, and you started talking about symptoms. So let's go down that roadway a little bit. If somebody is sitting at home watching this interview, and they start to recognize or maybe self-diagnose with some of the symptoms that you've talked about, maybe you could tell us about the journey that somebody might undertake to get some answers or to see if they need to be worried about diabetes.
Sure. So the first thing is that in type 1 diabetes and in type 2 diabetes, the symptoms are similar, but in type 1 diabetes, they're a lot stronger. So because the change is much quicker, and it's a rapid change when it comes to not producing insulin, type 1 diabetes has to be diagnosed early, and the sooner it even counts in hours. The sooner you get the treatment, the better outcomes you might have, and you might avoid diabetes ketoacidosis, which is another complication, severe complication that I haven't mentioned. Diabetes ketoacidosis is the effect of the lack of insulin. So when we have hyperglycemia and we have no insulin in our body, DKA, how we call it, diabetes ketoacidosis, is something that that is dangerous and might even lead us to diabetic coma. And diabetes ketoacidosis itself with hyperglycemia, chronic hyperglycemia, can also lead to death. So that's why before discovering insulin, type 1 diabetes was a fatal condition. That was the case for many people. So now we want to avoid DKA. We want to diagnose diabetes early. So we have these symptoms. We feel that we are very thirsty, and thirsty means we can drink 6, 8, 10 liters of fluids a day. We go to toilet very frequently. We are absolutely exhausted. We are losing weight. These 4 symptoms should definitely ring a bell here, and this is when we should go to see any type of healthcare professional, and the sooner the better. So if you go to GP, GP should refer us for a basic urine test, basic blood test. We can also go to see even a pharmacist and ask if they have any glucometer and check blood glucose level by a glucometer. If the sugar level is very much elevated, then we should be quickly transferred to a hospital, to our nearest emergency department, because this is type of emergency. So when it comes to diagnosis of type 1 diabetes, the sooner we react, the absolutely better. So that's the personal story for a person who is newly diagnosed with type 1 diabetes. Whereas with type 2 diabetes, it's much harder to get and it's much harder to recognize because it's a very, very slow process. Hyperglycemia is not that high as in people with type 1 diabetes. So often type 2 diabetes is recognized as part of some kind of annual screening when you see your GP. People are absolutely not prepared to hear that they have type 2 diabetes, but they see that their glucose levels are elevated, and this is based on that they are diagnosed with type 2 diabetes. However, if we feel that we are at risk of developing type 2 diabetes, and if we feel tired, if we feel that we have to go to the toilet frequently, we drink a lot, we might go to a GP and tell them, we have this kind of suspicion. I wonder if it's not type 2 diabetes. My mom has diabetes, my dad has diabetes. If we have a genetic load and the background in the family, this is what we should be screening for and check for. So I would recommend everybody over 40 at least, or even earlier, to make their annual blood test or urine test once a year, just to see if everything is fine, because this is how you can catch things early.
And with November being Diabetes Awareness Month, that's probably, if somebody's going to take anything away from this little chat, that's probably the best take-home message.
Yes, better to catch early, because then the reaction and intervention is a lot easier also, and less complications and lesser risk of complications.
3 years later, I was hoping we might get through a Midlands Science Festival chat or interview without saying the C word. But we're going to have to talk about COVID a little bit. Across the healthcare system, we're always hearing how COVID has impacted on diagnosis and screening and all the rest, and it strikes me that with diabetes, that's going to be a similar story.
Yes, absolutely. So COVID has affected access to healthcare professionals, has also affected the early recognition of symptoms. So what we definitely know is that incidence of type 1 diabetes is increasing in the COVID pandemic times, but also the incidence of DKA, so this diabetes ketoacidosis. So the situation when we recognize diabetes in the late stage, not in this very, very early stage, this is increasing as well. So it informs us that because the access to healthcare professionals was a lot poorer, it was much more difficult to get to be seen by someone, and our consultations were over the phone usually. Some situations, some incident cases were not recognized well. I believe it happened with GP practices and people with type 2 diabetes as well, that they haven't been seen too frequently. We all remember our phone consultations, but how can you make your blood tests or recommendations over the phone? It's very hard. In the hospital care, so secondary care, many clinics were not offering face-to-face appointments as well, so it was only over the phone. Some clinics were using the remote consultations mode, but from what I understand and from my own experience, it's just a call over the phone. And this is again why technology was quite helpful, because if I have a technology that shows my blood glucose levels, I can show it to my healthcare professional remotely as well. So many healthcare professionals learned that in pandemic that technology use is actually very helpful, because I can see remotely what is happening in my patient's life. And another effect that we see from emerging studies, because it's only, let's say, 3 years, even less than 3 years, diabetes might be an effect of a long COVID. So there are some associations, because it's a virus, and viruses often treated as a trigger for autoimmune responses. There is evidence that, for example, incidence of type 1 diabetes is increasing because of that, because of the viral load that is there. Of course, there was also another risk, especially in the beginning of pandemic, that people with diabetes who didn't have it well controlled, so people who tried their best, or even they weren't trying their best, to make their blood glucose levels in range or in appropriate recommended ranges, and they had very elevated glucose levels and chronic hyperglycemia. The mortality in this group was a lot higher when it comes to COVID, when they got COVID and when they got diagnosed with COVID. So definitely there is many interrelations between diabetes, healthcare, and COVID, but let's hope it's behind us and we are all back to face-to-face and practical advice of being seen by a healthcare team, and that we recognize and diagnose conditions early.
The media is a big influence on all our lives, but particularly something like diabetes, where it's a significant proportion of the population. Surely there are a lot of stories out there, a lot of things that creep out there that you look at as an expert and say, oh, that's not quite right, or I wish that was communicated in a different way. Are there any big myths or misconceptions out there that you'd like to take this opportunity to tackle?
Yes, absolutely. So yeah, the first myth, we already discussed it slightly. So the myth of type 1 being children's problem, type 2 being adults' problem. Not at all. It's very different, and any person of any age can be diagnosed with either type 1 or type 2, so we should be aware of that. But what usually happens in the media, because the prevalence of type 2 diabetes is much larger than type 1 diabetes, so we usually say that 90% of cases will be type 2, 10% of cases would be type 1. Usually media and journalists and everyone really thinks of diabetes more as a type 2 diabetes concept. So they have this kind of myths or misbeliefs that any type of diabetes is being caused by eating too much sugar only, or for example, how many sweets did you eat? And it's many people, especially those with type 1 diabetes, but not only with people with type 2 diabetes, are feeling very judged, and the language around diabetes is actually very judgmental, especially in the media. It's your fault that you get it. What have you done that you got it? It's not the case, especially when it comes to type 1 diabetes, but also with type 2, because as I mentioned earlier, some people might not have very healthy lifestyle and still not develop type 2 diabetes, whereas some people would be living their healthy lifestyle and still develop type 2 diabetes. So there is a myth behind that. So if we avoid judgmental language, if we avoid saying, oh, you ate too much sugar and what did you do? Oh, you're so fat, so that's why you have it. Of course, it's a quotation. I would never say that. This is something that we should definitely tackle and fight with because it just affects too many people, and they already have a big burden to deal with, and they don't need to live with additional burden of judgmental people around them.
Self-image and self-perception can have a big impact on how somebody manages their diabetes, and I'm wondering, do you feel that's emphasised enough? Is there enough emphasis put on mental health and well-being in the context of diabetes management?
Yeah, it's a very good question. I don't feel there is much effort put on improving people's mental health and well-being in Ireland. So, and psychology and mental health is extremely important. Of course, I'm biased here because I'm a psychologist by background, but because diabetes there is no other condition like this that requires you to make so many decisions and so many changes in your life to try to live with that, because it's a chronic condition. You have to learn how to live with that. It is a huge burden for many. It's a huge burden for families, for parents of children with diabetes, for adolescents, for adults with type 1 diabetes, for adults with type 2 diabetes, for families of people with type 2 diabetes. It might be a huge burden because it requires changes and requires constant monitoring and requires constant thinking of food, what you eat, how do you eat, where do you eat, etc. So yeah, people with diabetes, both types, are at much higher risk of developing depression, of having depression, major depressive disorder. There is a diabetes distress that can lead to diabetes burnout, which means that people are just completely tired of their diabetes management and they just let it go. And this is when it comes to be very, very risky and dangerous when it comes to developing diabetes complication, because what we have to do, we should control it somehow. We should do our self-management tasks. And if we are not doing it, this is where we put our lives at risk. So yeah, mental health is extremely important. Acceptance of the condition, the fact that we have to live with that, it's a big issue for many, especially in the beginning. The burden of diagnosis itself for families of children with diabetes, it's heartbreaking to hear that your child now has a chronic condition. But on the other hand, for a person with type 2 diabetes who just heard, yeah, you have type 2 diabetes and you're just, left on your own, go home, you Google, you see, oh, this diabetic food, or whatever. It's very scary, it's very lonely, and people feel that they might even feel grief, some kind of a grief, because of being diagnosed with chronic condition. So it takes time to learn how to live with that. There are so many people, so many examples of people showing that you can live absolutely fantastic, healthy, super active life. You can climb Mount Everest with type 1, type 2 diabetes. You can work as a commercial pilot. You can do anything. You can be in FBI if you want. So yeah, but this is the process, and this is strong resilience. That is also a mental health matter. I do believe, unfortunately, that in Ireland we don't put too much attention to mental health, unfortunately. Maybe it will change after COVID, because now we talk a lot more about how do you feel and how it may affect everything, really. There is only one psychologist in adult services, in hospital adult services in Ireland, who works 1 day a week, meaning that there's absolutely no whole-time equivalent for psychologists working as part of the multidisciplinary team in adult services. Psychologists are not included in enhanced community care schemes. So we have multidisciplinary teams, including diabetes nurse specialists, podiatrists, dietitians, but not psychologists. In pediatric care, it is a bit better because pediatric care sees the benefit of psychological input early from start when it comes to diagnosis, and then working with the family as a whole. So, and there's so many evidence confirming that having a psychologist as part of multidisciplinary team makes improvement overall for the group of patients, because you can talk whenever you need to, and you know who to ask if there is any issue. We do need more psychological support for people living with diabetes, because that's the way how we see it works in other countries, in the UK, in the United States, everywhere else really, but not in Ireland. So I wish to see more psychologists' involvement in Irish diabetes clinics.
At the end of these interviews, we always like to ask our guests if you could click your fingers and make certain things happen overnight to improve the landscape of diabetes care in Ireland, what would be the top of your wish list?
Well, this is again very, very difficult questions because there is a lot of gaps that should be tackled, and this is why we launched our pre-budget submission highlighting 10 issues that are facing diabetes health service in Ireland. But the most important, the priority one, consulted with national clinical leads, with healthcare professionals, and within the advocacy group that we have in Diabetes Ireland. The main priority for the community is to develop a diabetes registry and national diabetes pediatric audit. So there are two things. We need data, because if we have no data, we can't plan for resources, we can't offer access to services that people need. We can't see where the gaps are and where more investment should go when compared to other countries, or when compared to other cities or towns in Ireland. So we have no data, we don't know what the outcomes are, we are only guessing what is happening in Ireland, and that's why the first thing that I would really like to see is to develop the register and develop audits to see what can we improve, how and where. Otherwise, the HSE and other decision makers don't know what decisions to make if they don't have data. So that would be the first one and the main one. But from the others, I do believe we should have more specialists in diabetes. We should have more resources. We should have more diabetes nurse specialists, more dietitians, of course, psychologists. So every person, wherever they live in Ireland, they should have access to multidisciplinary team. And now this is kind of heterogeneous, let's say. There is a great initiative, Enhanced Community Care, and it's a huge investment as part of the Slattery Care program and implementation. And it's a fantastic initiative because it brings type 2 diabetes treatment and recognition to community care. So there will be specialists, and there are in some places already specialist community hubs with dietitians, diabetes nurse specialists. So people being treated with general practitioners can be referred there to get their education, intervention quickly, etc. So it's a great initiative, but what is an issue? It's for now, it's only for medical, general medical card holders or GP card holders. So if you are a private client of a general practitioner, you have no access to those fantastic resources. So yeah, I would like to see it available for all based on needs and not based on the means. So this is another issue. Of other issues, yes, long waiting lists, lack of access to structured education programs for many, for both type 1s, type 2s, secondary care, community care, no access to technology, very low uptake of technology when compared to other countries. So people are waiting for years to get their insulin pumps, people are waiting for long to get their continuous glucose monitors or flash glucose monitors. By the way, flash glucose monitors are still not reimbursed in Ireland, which places Ireland as the only one in Western Europe that doesn't have reimbursement for people over 21. So it's restricted by age. And it's kind of funny because flash glucose monitors are produced in Ireland. There are so many jobs for people employed by the company. They're exported to hundreds of countries, whereas people in Ireland cannot use it because they don't have reimbursement for that. So yeah, there are many issues. There's also another issue about women with gestational diabetes because they have to pay out of pocket for their treatment. And I do feel, and we all feel in Diabetes Ireland, it's a bit unfair because medicines cost a lot in Ireland and they have to pay a lot. And it's a matter of health and well-being, not only women, but the child that is going to be born. So these are the main issues that I wanted to tackle, but everything is described in our pre-budget submission. And if anyone is interested to see what should be changed and how, please visit our website, www.daibetes.ie, and you will find it, because that's the role that we do. We advocate for change and for better care for people with diabetes.
So I just want to say a big thank you to Kate and to Diabetes Ireland for participating in this Science Week event with Midlands Science. Thanks to you for watching, and we'll talk to you again soon.